Thank you, Francine, and thank you, Philippe, and the organizing committee for inviting me to present something about this mess of frontal lobe seizures. Really. So I will start with anatomoclinical correlation in orbitofrontal seizures. So the first description, this is the slide that we skipped, were from Penfield and Jasper, and then Banco, and a few ones. They were the original seminal description that I found, and yeah, okay. And their common findings were that the first description all had in common the same etiology, post-traumatic epilepsy. These cases did not report aura, in contrast to the rich literature that already existed about autonomic symptoms elicited by electrical stimulation of this area. And these seizures were described as either asymptomatic or following two distinct clinical patterns, what they call psychomotor fits, or loss of consciousness, head and eye deviation, and secondary generalized tonic-clonic seizures. And there was a debate about the pathophysiology of observed ictal signs, whether it was related to the orbitofrontal discharge itself, even when it remained confined in this cortical region, or to the propagation. Yeah, so we skipped the anatomical introduction, but so the brief classic view on the topic from Munari and Banco from this very important book, Frontal Lobe Epilepsy and Seizures, published in Advance in Neurology in 1992. The conclusion from Claudio Munari at that time, that I quote in this slide, were that ictal discharge can start in the orbitofrontal cortex. It was debated at that time, it seems, but never remained localized to the orbitofrontal cortex. That the second conclusion was that the absence of observable ictal sign is actually the most frequent pattern of discharge confined to the orbitofrontal discharge, to the orbitofrontal region, as long as and what was very modern already at that time is the concept that the electroclinical or the clinical semiology emerged from the propagation, from a trajectory from orbitofrontal to another cortical regions. And they distinguished four patterns of propagation: mesial temporal, frontal, mostly cingulate, lateral temporal, and opercular. So the main issue that remained for the orbitofrontal cortex seizure actually are the same for the entire frontal lobe, that the frontal lobe, as Philippe kindly reminded you this morning, is a mess. So semiologic pattern of orbitofrontal as well as other prefrontal seizures are difficult to characterize. And their predicting value in terms of seizure onset and sublobar localization remains unclear. There is also this ongoing debate that somehow we need to localize a seizure onset, but that in fact the clinical semiology is more easily understood as resulting from a continuous caudoventral functional gradient, rather than resulting from distinct, clearly separated sublobar regions. And still, they are crucial in terms of accuracy for ECG planning or assessing the concordance between an MRI abnormality and the presumed seizure onset. So I will not waste too much time on the selection. Just to remind you that I excluded from this review the papers reporting less than 10 cases, which in fact it was papers reporting one or two isolated cases. So from the search that I did, I had 190 hits, and it resulted in 26 articles that I reviewed, and I selected 7 of them for a total number of patients of 135. And so let's get in the topic now. It was very difficult, it was impossible, in fact, for most of the studies to determine the proportion of pediatric and adult patients. The average age was between 23 and 42, depending on the study. The rate of MRI-positive cases was a little bit lower than it is now in our database. Or if we compare to the rate of MRI-positive cases from the paper from McGonigal, it's almost the same, actually. It's a little bit lower, but almost the same, 60%, between 50 and 65%. Of course, because of the criteria that we use of selection of the study, the percentage of intracranial explored patients was very high. They were actually all explored with a CEG. And as well as the percentage of operated patients. And the confidence in the epileptogenic zone was high in all but one study from Kriegel, where the description of the cohort was actually very general. I hesitated a lot about including this study or not in this review, but I finally did it. But the contribution is quite low, I must say. So this is basically the same information. Just to show you that the percentage of class 1 in this 135 patient review was quite high, with a median of 76%. So maybe it's not such a mess. Or at least the mess does not prevent to do a good job. So let's start with the aura. Yeah, in this review, most of the studies did not report individual data. The individual data that I got were from the smallest case series, where I could get some tables. But for example, in the study from Gibbs that I really wanted to include from the Milano group, it was about sleep hypermotor epilepsy. Speakers already mentioned this study yesterday. But the main issue was to distinguish semiological pattern in relation to frontal or extratemporal origin, frontal or extrafrontal origin. And so the correlation at the sublobar level of the frontal lobe were not so easy to do, except for the semiological pattern that they considered, so the motor manifestation pattern. So for the aura, it was not possible to get some data from this series, although it's the second one in terms of patients with presumed with orbitofrontal seizure onset. So what I can say from this review is that the main auras, the main subjective symptoms were olfactory, viscerosensitive or dysautonomic symptoms, and fear. But there were also some other non-specific or bizarre subjective symptoms. And as you can see, the percentage was ranging between 26 and 64%. So it is not something to be overlooked. It is really something to look for, and not so rare, actually quite frequent. And in terms of anatomo-clinical correlations, only two studies allowed to make some correlation. The first one from Munari and Banco that I included, of course, in this review, and where for each one of these category of auras, either olfactory or fear or non-specific, in all these cases, it was related to orbitofrontal to temporal lobe propagation. This is the way they presented it. And if we consider the paper from Bonini and McGonigal, the fear is actually the only aura that they reported, and it was in the category of patients where in the group of patients where the seizures indeed propagated or involved, or primarily involved, the temporal pole and the amygdala. Regarding the autonomic signs, there was a wide range of dysautonomic symptoms that were reported, but in most of the study, these autonomic signs were overlooked, unfortunately. or not reported or not described according to the sublobar origin. So I think that this is really something to look for more carefully in the future study and in our unit, in an epilepsy monitoring unit, to look for more carefully and more comprehensively all these dysautonomic signs. And so I only found 2 studies that reported, so the one from Munari and Banco again, and the series from Zhao in 2020. So it's very difficult to make some conclusion about these autonomic signs, and the range was, their frequency was ranging from 4 to 45%. 3 studies, excuse me. And only one with a correlation of anatomoclinical correlation from medial orbitofrontal to mesial temporal lobe. So let's start with this very important paper from Bonini and McGonigal. Again, I hesitated to include this paper, but it was not possible to skip it for both the importance of the theory, but also for the nice methodology and the conceptual, the concepts behind the methodology, that semiology should be considered as, that symptoms in terms of anatomoclinical correlation should be considered as cluster and not isolated to understand the semiology of such a complex region. And 2 groups, and these, I will just remind you that these groups were not constructed with a priori ideas, but were resulting from automatic classification methods, so quantifying the co-occurrence of symptoms together. And so 2 groups corresponded to a possible orbitofrontal origin, the group 3 and group 4. And group 3 was characterized by distal stereotypies, integrated gestural motor behavior, so with a very naturalistic component when you're looking at it. Manipulation utilization behavior, which remind us of the usual clinical signs after a orbitofrontal lesion. No emotion, or when there was a manifestation of emotion, it was joviality, it was a positive manifestation. Proximal stereotypy, and importantly, the lack of elementary motor signs. And as you can see, it was related to areas involving the orbitofrontal cortex, Brodmann area 10, 11, 47, 12, but it was not possible to distinguish it from an involvement, a primary involvement of the singular and paracingulate region. Okay. And the second group was group 4, and this group 4 was comprised negative emotional affective expression, feeling of fear, anxiety, rage, speech production, integrated gestural motor behavior. So this is a group of naturalistic behavior with a strong negative emotional content. It comprised autonomic signs also, which is consistent with this emotional integrated behavior. And again, as a negative sign, exclusory sign, the absence of elementary motor signs is important. The second study that I wanted to get into more precisely is the study from Milano Group, Gibbs, at Collaborateur, where in this study, they don't use automatic classification. Basically, they rely heavily on this paper and from Bonini, and they propose a priori 4 different semiologic patterns. And as you can see, their patterns 3 and 4 are very, very comparable to the patterns of described by Bonini and McGonigal. And they described that they took elementary motor signs as signs that were excluding patients from this group. Interestingly, the inter-rater agreement was excellent between 0.7 and 0.9. And if we go now to the localizing, to the anatomoclinical correlation, as you can see, pattern 3, which was this naturalistic integrated behavior without emotional content and distal stereotypy, could be localized either on the mesial or the lateral orbitofrontal cortex. But as you can see, this pattern can also be encountered in seizures starting in the cingulate or paracingulate area, and even on the ventrolateral, on the dorsolateral part of the prefrontal cortex. So this is not pathognomonic, of course. And the fourth pattern was integrated behavior with the strong emotional and negative emotional content seems to be more specific to the orbitofrontal region, mesial or lateral, with a slight predominance on the mesial aspect. Again, the interesting part of this paper also are actually the exclusion characteristics among sleep hyperkinetic epilepsy, considering early motor semiological pattern, so early clonic signs, asymmetric tonic posturing from the pattern 1, or the hyperkinetic component of the semiologic pattern 2, where seemed to be on this series, excluding from orbitofrontal origin. So there is a third semiologic pattern that was not described in these two important series, but that I found in the series that focused on orbitofrontal seizures, and especially in Munari, Zhao, Shiban, Krieger. And this pattern, I called it temporal or amygdalopolar, so characterized by a behavioral arrest, oroalimentary automatism, and or gestural distal automatism, typical of temporal seizures, long duration, the presence of autonomic symptoms, and it can comprise or not emotional content. Okay, and I retained this pattern, semiologic pattern, because of course it was an important pattern in 4 of the studies that I found, and it's also a pattern that we encounter in our everyday life, I would say, in our monitoring unit. So the median frequency of this pattern are respectively 43% for the integrated behavior, 26% for the integrated behavior with fearful emotion, and 15% for the temporal. So it's not 100%. Of course, some of the cases still escape from this classification. And the integrated behavior without emotional content seems to correlate quite nicely with an involvement of the orbitofrontal cortex. Some authors emphasize the lateral involvement, but it can be also mesial. And what is important also is the rapid and important involvement of the cingulate and paracingulate region. Whereas integrated behavior with fearful emotion seems to be a little bit more specific of mesial orbitofrontal and are characterized with a propagation to amygdala and anterior temporal region. Actually, as well as the last clinical pattern, but where the semiology, temporal lobe semiology is more prominent. I have 2 examples, but I know that...
I do my job.
Yeah. Just one case of lateral orbitofrontal to rostral cingulate propagation, and you will see with the utilization and manipulation behavior. Just to tell you that this behavior of manipulation utilization, we did not see it during the phase 1 investigation because he was lying in his bed without any object around him. So in frontal lobe, and especially in orbitofrontal lobe seizures, the semiology clearly depends on the richness of the environment. If there is nothing around, of course, you will not be able to see a utilization manipulation behavior. So here there was an ipsilateral version, and a manipulation of the bottle, manipulation of the cable, and even some kind of manipulation with the foot, because as you will see, he will push the table and then move the table and push the table and then move the table towards him. And the onset was orbitofrontal lateral, and the propagation was to rostral cingulate. Okay? And there was no loss of consciousness during the seizure. And another one, which is mesial orbitofrontal. So now the discharge already started, and it was completely asymptomatic here, as long as the discharge indeed remained in the orbitofrontal. And there were several other seizures where it remained in the orbitofrontal and stopped, and the patient was examined at that time, and he did not report anything.
Vous avez rien senti là?
So now it propagates to the mesial frontal pole, X. And the patient is able to talk with the technician, and now it propagates to the mesial temporal structure, the amygdala, the hippocampus.
Vous allez retenir le mot bateau.
So he is asked to memorize a word. And the discharge also involves more largely the orbitofrontal and frontopolar area, lateral aspect of these, and the basal temporal area also, and the temporal pole.
Ça, qu'est-ce que c'est?
And there is no verbal interaction.
Vous allez suivre du regard non.
So the seizure is mostly characterized by a behavioral arrest. He had some chewing automatism. It's difficult to see them because the view is a little bit too far, but it was reported by the technician. And the seizure will last for a very long time. There is no need to watch it until the end, but as you can see, it was a typical third pattern of mesial temporal amygdalopolar, I would rather say, propagation type. So my conclusion are that no single symptom or sign specific of discharge remaining in the orbitofrontal region. Very variable electrochemical delay. Only one study mentioned this point. It was again the study from Munari and Banco, 6 to 60 seconds. When confined to the orbitofrontal, the discharge is most often asymptomatic, and 3 semiological patterns according to 2 main trajectories of propagation. And I already gave you a detailed description of these different patterns. So a more general conclusion is about the syntax of ictal semiology. If I ask you, okay, which one of these 2 French poets wrote a poem with the word temps? You have Alphonse de Musset on your left and Paul Valéry on your right. Actually, both of them. And it's impossible just on this word to say, okay, who wrote this word? If I give you an entire sentence, but just a verse, « Ô temps suspends ton vol », or « Le temps scintille et le songe est savoir », then, of course, it's easy.
Everybody knows that.
Of course.
Especially
So, yeah, of course, « Ô temps suspends ton vol », we would like, the time to be suspended while we are here. So, as for poetry, understanding anatomo-clinical correlation requires to consider the entire sentence of signs and not single isolated symptom. Thank you for your attention.